My guest today is a top doctor and a double board certified plastic surgeon in Beverly Hills. He specializes in aesthetic, cosmetic, and reconstructive surgery. He has been in practice for over 16 years, and he is an incredible plastic surgeon. He specializes in breast reconstruction, and I am not only a big fan, but I am a patient, and he is amazing. Welcome, Dr. Brenner.
Thank you. Good to be here.
Good to be here. I'm so glad you're here. This is different.
Finally, we did it.
Yes. How does it feel to be on the other side of the chair?
It's a very different experience.
So I want to talk to you a little bit about the hot button topic that is going on right now, which is BII, which means breast implant illness. And this is something that you see all over social media now. I am so surprised on every day. It's tons and tons of women coming out.
Yes.
And I'm not only speaking from somebody who's looking at it, but I also suffered from breast implant illness. Could you tell us a little bit about that?
Sure. Well, first of all, you're 100% right. This has been social media driven from the beginning. That's why you're seeing it all over social media. This has been a patient-driven phenomenon, which has really forced us as physicians and surgeons to A, take notice, and B, kind of take review of what our normal standard practices have been for so many years. So, and what breast implant illness is a constellation of symptoms which are attributed to having breast implants in. And the reason why breast implant illness has been such a hot topic,
Burning hot
controversial,
topic. Yes.
Certainly controversial.
Yes.
In my world, among plastic surgeons, controversial among, FDA, controversial among all the medical societies, the plastic surgery societies, and the implant manufacturing companies.
Right.
Because there really is no way to test for it. So it really comes down to listening to the patients and sort of putting together a picture of chronologically what happened, and then specifically like what the patients are dealing with and what they're suffering from, and then ruling out other disease processes that can have similar symptoms. Because, I mean, if I'm being perfectly honest, it doesn't make sense. The BII symptomatology doesn't really make sense,
right,
until you kind of step back and look at it and say, well, maybe these patients are just having some sort of immune mediated reaction to having a implant in their body. And when you look at that and sort of instead of dissecting each one, you can see that there's actually maybe something to it, which a lot of people don't necessarily believe.
Well, yeah, there's 4 pages of symptoms. So look, of course, logically you go, oh, well, of course you're going to have something. But speaking from experience, I spent 3 years in and out of the hospital with acute pancreatitis and feeling like I was being poisoned. And my pancreatic specialist, when they couldn't figure out, they sent me to the top guy at Cedars that everybody sends when they can't figure it out. He couldn't figure it out. And I just kept being told that I had an autoimmune disease. And
Right.
So I started doing my own research and really removing my implants or doing the end block that you did for me. That I found this is my last hope. And I literally was at home getting IVs twice a week. I was so sick. And
pancreatitis is a real thing.
Yeah.
Pancreatitis happens. I mean, before I was a plastic surgeon, I was a general surgeon. I took care of patients with pancreatitis all day, every day. I mean, that's kind of in the wheelhouse of general surgeons. And, people get pancreatitis. People without breast implants get pancreatitis. So to take the leap and say, well, maybe this is being caused by a breast implant, like, it doesn't make intuitive sense to anyone, including me. Like, why would a breast implant cause pancreatitis? There really is there's no rational reason for it. And there's also is really no way to test for it, which is why I think people are so skeptical about believing that it might actually be a
I
thing.
was skeptical,
Yeah.
but I have a surprise for you. My blood work.
You repeated it.
Yes, I did. I told Danny I hadn't because I wanted to surprise you.
Oh. Well, no one told me.
So she didn't know either. I wanted to surprise you. 8 weeks.
Look at that. Where's
yeah.
the date on this?
So
This
that was
from,
3 days ago.
3 days ago.
Yeah.
Oh, fantastic.
Isn't that amazing?
Look at that.
So
your lipase is totally normal.
Normal. It hasn't been normal in 3 years.
We actually postponed your surgery because
my lipase was elevated.
Well, your lipase had been elevated, and your gastroenterologist had been kind of tracking it, right? And then right before we were going to do your surgery, it spiked.
Yeah.
For no apparent reason. So he put you back on your medication, right?
Yes.
And we waited 2 months or so for it to everything to calm down.
And it's still, when I had the surgery, it's still elevated. I haven't had a normal lipase in 3 years. I'm 8 weeks out. This is the first time I've had.
Well,
I have
congratulations.
goosebumps. I have goosebumps, Dr. Brenner. You did that. You really listened.
Well, your body did it.
Well, no, but I mean,
body healed.
You are helping women, and and I got to say, it's being a patient, you kind of bring this up to doctors, and they kind of roll their eyes a little bit
because it doesn't make sense.
I know,
it doesn't make any sense.
I feel like a different human being. I mean, I'm sure that you and your staff can see the difference that I feel from when I first went in there. I couldn't even get up from the couch to walk my dogs. So in 8 weeks, I'm like speed walking 4 miles. I'm not running yet because it's been 8 weeks out. So Dr. Brenner, do you see a difference in patients when you do the explant, remove the implant? And also, do you recommend that you remove the capsule?
I do. And I think we sort of touch on it. The data is not quite there yet. But when patients come in with symptoms of breast implant illness, then I really think that they have breast implant illness.
Right.
The implants and the capsules need to come out. Almost universally, patients feel better. Almost universally. I mean, I think I can think of one patient in the last 3 years who did not have any change in her symptoms after surgery, but I really also don't think she had BII. She also thought she had ALCL and other things, and I think she was just kind of freaked out because of all the media hype. But it's remarkable actually that even the day after surgery, because I see all my patients back the next morning.
I felt high, like euphoric the day after.
That was probably the drugs talking.
No. You should see I'm going to post on I'm going to do an insert of my before and after, the day before surgery and the day after, 1 day after. My chest, my face is rosy, and I was gray before.
It is interesting. And I've talked to other surgeons across the country who are starting to take before and after photos, not of the breasts, but of patients' eyes, and notice a huge change, even 24 hours, which really doesn't make any sense. You're like, well, maybe it's just swelling and the anesthesia.
It makes sense to me.
It really is kind of crazy.
Yeah.
It really is kind of crazy that people feel so much better. And you know what? If it's taking the capsules and implants out that makes them feel better, great. If it's a placebo effect, okay. They still feel better. I mean, they all feel better. And I think, if you can do it safely, I mean, a lot of people just don't want their implants anymore anyway. And so if I can do it safely and still make their breasts look good, I mean, that's what I do anyway.
So you do recommend taking out the capsule also. I'm glad I did everything, because that way, for me, there will be no doubt in my mind as if I would have left the capsule, I think, and then I didn't feel as good. I would have been like, oh my God, I should have taken So I think for peace of mind also, as a patient, from a patient's point of view.
It also is technically easier for the surgeon to do it at the time that you're removing the implants, because you can kind of follow the path of the implant as opposed to, searching for a needle in a haystack a year later. It's possible to do it. It's just a little bit trickier.
I want to talk to you too about what we did. We did an end block, right?
Right.
So can you explain what that is?
Sure. So when it comes to breast implant removal, right, you can go in and just take out the implant, or you can go in and take out the capsule that surrounds it.
And the capsule is?
So the capsule is a specialized scar tissue. Any implant that people have in their bodies is a foreign body, whether it's a breast implant, a chin implant, a pacemaker, an artificial knee. Your body recognizes it as a foreign entity and very specifically walls it off because it's a foreign body.
Kind of to protect your body from.
To protect you from the implant,
right?
No matter what the implant is. So people who have pacemakers in their chest, you might be able to feel it. It's superficial. They're made out of metal, so it's very different than a silicone breast implant. But it also has a capsule around it,
right?
And the capsule is the same kind of metaplastic, specialized type of scar tissue that surrounds it. Now, normally, that tissue kind of lives in harmony with the implant, and it's usually very thin and pliable. And I often describe it to patients as oftentimes as thin as the fibrous membrane on an egg.
Oh,
like
wow.
when you take take a hard boil an egg and you peel off the shell and there's
a
fibrous
right.
Sometimes it's that thin, like so thin that you can read a newspaper through it. Sometimes, however, you can have patients who develop an entity called capsular contracture, which we know in our publications, in our literature, has a infectious origin. It doesn't mean that the implant was necessarily infective, but somehow at some point in time between the implant being put in and the time that they develop a capsular contracture, some type of bacteria makes its way into that space. There's a kind of a space in between the implant and the capsule. Right? So it also doesn't make a lot of sense, because you would think, well, if there's bacteria there, why isn't there pus? Why isn't it become infected and red and hot and work its way out of your body?
Right.
That would be a normal thing. But it doesn't. But there are some bacteria that create what's called a slime layer, and it can attach. And once you have a foreign body that has that, you can't get rid of those bacteria until the foreign body is removed. So when patients who have capsular contracture, it's the same process. You go in, you take out the capsule, you take out the implant, wash it out, and you're done. So and so I think sort of the thought behind that with breast implant illness was that if the implant, for whatever reason, is making people sick, that perhaps the capsule is.
Right.
Truthfully, there's no data that shows, even today as we speak, there's no study that shows that taking out the capsule, taking out the implant with or without a capsule, actually has any effect, positive or negative, on patients' symptoms.
Right.
Just because it hasn't been studied, not because it doesn't necessarily mean that it's true. It just hasn't been studied. So, and again, this goes back to this being a kind of a patient-driven phenomenon. Somewhere along the line, some patient latched onto the term en bloc, which is a term that we use in cancer surgery for soft tissue tumors, and where you go in and you remove the cancer with a layer of normal tissue, non-cancerous tissue around it, so that you take it all in one piece, so that you're not spilling cancer cells, whether it's
spreading.
Right. So whether it's a breast cancer or some sort of soft tissue sarcoma, whatever it is, you want to take it out in one piece. So that's where the term en bloc comes from. It's a little bit of a misuse to use it in this sense, because the capsule is not a cancer. Cancer cells you can't necessarily see, right? You can feel a big tumor, but sometimes there's other microscopic cells that you can't see.
Right.
Capsule you can see with your eyes, and so you can, as a breast surgeon, because been doing breast surgery for a long time, you can go in, you can very clearly see where the capsule is. Sometimes it's a thin capsule, and it tears just like when you're peeling an egg.
Right.
And sometimes it's a really thick capsule, and it gets hard
out.
And it just comes out much more easily. So that's where the term en bloc comes from. I shy away from using that simply because I think it's a misuse of the term.
So it's the same as,
So what, the term I use is a total capsulectomy, which means that I'm taking the entire capsule out.
which is what you
Which
would
is really
recommend,
what
right?
we want anyway. Yeah.
Yeah.
Well, some people, whether they're physicians or non-physicians, think that in that space that we talked about, that
Right.
there's some sort of toxin that's being emitted from the implant. And maybe there is, and maybe there's not. I mean, there are a lot of chemicals that make up the shell of a silicone implant, even if it's an intact implant. Sometimes with a silicone implant, you can have a non-ruptured silicone implant, and there's an entity we call gel bleed, where the silicone actually works its way through the shell, even though it's not
wow, that's
ruptured.
crazy.
And you have the little slimy. You can have a little bit of a slimy layer around the implant, which tells me that it's porous to some degree, right? So, obviously, if you have a ruptured silicone implant, taking the capsule out in one piece without any holes or anything is a huge advantage because the silicone's not spilling all over the place when you're doing it. So technically, as a breast surgeon, it technically makes it an easier removal, right?
Well, also, when you do, let's say, remove the capsule and the implant, you also recommend some women might need a lift and reconstructive. Most.
Many of them. Yeah,
Right?
I like to call it aesthetic reconstruction.
Let me tell you, I got a lift and they look spectacular. It reminded me of the Seinfeld episode, remember with Terry Hatcher? And
Yes.
they wanted Elaine,
Yes.
they were like, and she was
They're
like,
real
they're real
and
they're spectacular. I can say that now. So could you tell us a little bit about your procedure? Because I know that your lift is a little bit different than like the majority of doctors do.
The way I prefer to do it,
Right.
It's not always possible to do it the way I like to do it. It's just the superior base technique that maintains the tissue in the upper portion of the breast. And I started doing that first initially with breast reductions, where you're removing tissue, and I always like to remove the kind of the heavy hanging lower tissue and keep the upper tissue so that it's perky. And what happens is it allows me to contour the breast along the lower pole, which gives a better shape to the breast, and long term,
More rounded, like, right?
a little bit more rounded. Yeah, I mean, my biggest criticism of seeing there's a technique called an inferior pedicle, which is kind of like the workhorse pedicle. What a pedicle is where the blood goes to and from the nipple, because we want to keep the nipple alive when you're doing a reduction or a lift. So the inferior pedicle maintains the blood flow from the south, but that tissue, in order to keep the blood flow, you have to keep the tissue that the arteries and the veins run in, right? So that tissue is in the way, I think, for me.
Right.
Gets in the way. So what happens is, the breast tends to be a little bit square, a little bit boxier, and tends to
bottom heavy.
fall south over time.
Right.
And so I just think I get a nicer shape to the breast using the technique that I use. I'm not the only one that does it that way, but I've gotten really good at it. And I took that and kind of waylaid it from the breast reduction patients over to the breast lift patients, and then from the breast lift patients to the explant patients with the lift. It just gives me a little bit more flexibility in terms of what I need to do. And yes, you're absolutely right. I do a lot of breast lifts because, my thought is, women come to me and other plastic surgeons to have breast implants put in because they want an attractive breast. So
it's true.
So I want to do everything that I can to leave them with an attractive breast when you take the implants out, take the capsules out. It's not always possible. I mean, there's, for a lot of reasons, everyone's different. Everyone's tissues are different. I mean, some, people are at an advantage if they have a lot of breast tissue. They're at a disadvantage if they have very little. I see not only does the skin get stretched out, the breast tissue gets stretched out. I recently had a patient who had the most profound chest wall remodeling I've ever seen, and that's simply from having an implant sitting in between your chest muscle and the rib cage.
That sounds painful.
Years and years and years of just, exercising, doing push-up, whatever you do in your everyday life, and having that push and push and push. And the chest wall is a living, breathing thing. Rib is a living, breathing thing, and so it will respond to pressure. Whether it's cartilage or the bony portion, it will respond to pressure and leave a little bit of a scalloping or an imprint on the chest wall. So if you take someone who was, let's say, A cup or smaller, very flat when they first
got it,
and had very little breast tissue, and then you put an implant in, and maybe it looks great with the implant in, but you leave it there for 10 years and you take it out, you're not going back to the starting point. You're actually going, it's actually worse than where you were before you had it put in, because you have, just by having had that implant sit there for 10, 15 years, whatever it is, it has actually increased the space. It's actually pushed your chest wall back. And so whereas you may have been neutral and flat to begin with, sometimes you can end up being indented even with no change in your actual breast tissue.
But the beauty of that, because, yes, women are, for me, like BII, when I first read about it, and then when I was going to have remove my implants, I thought about like how it was going to affect me mentally to see my body different, to see like, are my breasts going to be deformed? Am I going to be flat chested? But then you have something else that you do that is, really cool, which is fat grafting.
Yes.
So even if you remove your implant, right, and you're not as full after you get a lift, you can do fat grafting.
You can get more volume. Again, very patient dependent, because you have to have some fat. I mean, I have, usually the issue is the people that need it the most have the least amount of fat, right? Because if they're skinny and have no breast tissue and their torsos like this, then oftentimes they don't have fat in the rest of the body. But that's not true across the board at all. And I have some patients who just want more breast tissue, and if I can kind of rob from Peter to pay Paul, I think why not? It's a great procedure. I've been doing fat grafting to the face for facial rejuvenation, and to the breast in conjunction with breast reconstruction for years. And some years ago, plastic surgeons started doing it as an aesthetic operation, right? So some surgeons even do it as, which I now do a lot of as a result of all this, for primary augmentation. So instead of an implant, doing fat grafting.
That is amazing.
Which is great. I mean, you don't get as much volume as you would with an implant, but some people don't want that much volume. Some people don't need that much volume.
Right.
So it's a great procedure when it works. And even if I can get a little bit more volume, or oftentimes maybe some patients don't even need more volume, but maybe there's some asymmetries that exist after we do a breast lift. It's really useful to help correct those asymmetries. If I can do it, great.
Right. Well, the beautiful thing about fat grafting too is not just for the breast, but you can, they're using it as filler now. You put it in your lips, you put it in your cheeks, right?
All the time. Yeah. And it lasts longer.
Yeah. Oh, it does.
Nice. You don't have to keep coming in every 6 months to have your Restylane and Juvéderm.
Well, we need to talk. So let's say when you do the fat grafting, can you explain what that procedure is like? When you do the fat grafting, you remove it, how much of, let's say, the fat actually stays with you? Because I understand that sometimes it's not 100%. There's a percentage of the fat.
That's absolutely true. I don't think I've ever had a patient who had 100% retention of the fat. It just doesn't exist. A couple factors. Number one is how the fat is harvested, how it's retrieved from the patient, in terms of the technique, how it's processed in the operating room, and there's so many different publications of different surgeons with different techniques and like how they like to do it, and then it's how it's injected. You can inject 1 cc at a time, or you can inject 50 cc's at a time. If you just slam it into the breast tissue, it's not going to do very well. You really have to finesse it. And then also probably the more important is what we call the recipient bed, right?
Right.
The
What is recipient bed?
That means where you're putting the fat.
Okay.
So you can't. So whereas with a breast implant, you can make a pocket and just put it in because it's an inanimate object. It doesn't require blood supply to heal and live there. It just your body just kind of encapsulates it. Fat grafting, like you don't take out the implant and just replace it with fat in the same space. That is a recipe for disaster. It's not going to work. The fat that you take out, let's say you take it from your thighs or your abdomen or your waist, that fat before you've removed it is a living, breathing thing, right? It's getting blood. It has blood flow going to it. It has blood flow coming from it, bringing to it nutrients and keeping it alive, right? So you have to keep it alive.
So you'd want to transfer
After
it.
you transfer it, it needs to stay alive. So your body, the way it stays is your body grows new blood vessels into the fat. So I always like to use the analogy of like an apartment complex. If you have a 100 apartment complex that comfortably sleeps 100 people, but you shove 500 into that apartment complex, you're going to have problems. People are going to start jumping ship left and right, and not everyone's going to make it through. So that's why I do feel like there's a little bit of a limitation to how much you can do at one time.
Right.
So,
yeah.
and I'm pretty conservative with it. I think once you get to a certain volume, if you go over that, then you're just kind of wasting the fat and actually hurting yourself and hurting the chances of the fat to survive.
So let's say with like when you're transferring, like if you have, let's say, remove your implants and you just get a breast lift, do you recommend doing a fat transfer within that same procedure, or do you recommend, like, let's say if you get your implants removed and you get a lift, would you do the fat transfer at the same time, or would you do that later?
That very much depends on the patient.
Okay.
And again, have to listen to the patient in terms of what they want. A, B, it also depends on what canvas you're working with. If you have a young patient with a perky breast who doesn't need to have a breast lift, they just want a little bit more volume and they have some breast tissue to graft into, then I can do the explant and then graft them immediately and get a reasonable take.
Mm-hmm.
Sometimes you have to go back and do a second round. But if you have someone who let's say had their breast implants put in 20 years ago, and then they went and had a couple kids, and then they breastfed those kids, and now their breasts are kind of hanging off of their implant and they need a lift anyway, and then they develop BII and they want their implants out, or, which I have a lot of patients who don't have BII at all, but have that same scenario. They had implants put in their 20s, they went and got married, had kids. After having kids, their breast just kind of got 2 sizes bigger than it was before, and they stayed bigger, and suddenly they went from being happy with their CD cup to having like a G cup breast that they never really wanted, and so they'll come and have the implants removed and then kind of do like a lift breast reduction at the same time. So I have that that group of women as well that come in.
I love having the alternative, but I'm not here to try to convince anybody either, because every woman is different. Some women may experience it, some not, but it's nice to have options where before you really didn't have options. If you wanted your breast to be either bigger or fuller, you had to go with an implant. It's kind of nice to know now that you can use your own body fat and actually, in many different areas.
It is nice, and it'll I'd be really interested to see kind of what happens with the BII population. I mean, I don't think that's going down anytime soon, because
no, it's actually going up. I read the study.
About 300,000+ implants are put in every year in the United States.
Yes. Yeah. And I just read this that said a breast augmentation is the #1 cosmetic surgical procedure in the U.S. since 2006. And it said it dropped 14.9% from 2018 to 2019. Nice. And according to the Aesthetic Society, explant surgeries, on the other hand, have like increased
14% or something.
34.4%.
This is the first year that I've ever seen a drop in breast augmentation numbers across the board. Not my practice. I'm talking about across the country. I mean,
Right.
yes, in my practice, but across the country. I mean, in 2020, I took out way more implants than I put in, for
And
sure.
it's shifting now.
By huge.
Yeah. Do you think are you recording any of the women? Like, is there anything that doctors are doing to kind of like maybe have some kind of report of like how women feel, after they have their
I'm glad you brought that up, because first of all, I feel like any surgeon who has sort of embraced BII is sort of sailing into the wind. There's a lot of noise out there, and there's a lot of animosity from other surgeons.
I'm sure there's a lot of pushback.
A lot.
Yes.
Well, I mean, you have to think about it from other people's perspective. If you have a business where your business model is to put in as many implants as frequently as possible, and that's primarily what you do. I mean, plastic surgeons do a lot of different things. My practice is certainly diverse. I've never had a practice that was built on breast implants, but
Right.
some surgeons do. So if that's your model, and suddenly you have a 15-20% decrease in your business, or perhaps even more, or perhaps you have legislation that makes it more difficult, that's a huge ding on the bottom line. So it's understandable why people are resistant to even hearing about it. And if I'm playing devil's advocate, there's really, as a physician, we really kind of base a lot of what we do on data.
Right, but there is no data.
There is no data. So there's some data. There's one study that came out that was helpful. There are more studies. I will tell you that in our spring meeting with our society, that it was a virtual meeting this year, so it was easy to go to. Which was great. It was the first time I sort of saw a tide shift, where there was more than a handful of surgeons who were at least open to hearing about it. The research foundation of our society is actually doing a huge study on BII.
Well, that's good to hear.
And kind of on the heels of that, I was given a sheet of kind of a screening questionnaire that I've sort of adopted it and amended it, and have been using for my patients. So because I want to know, like, 0 to 10, what symptoms did you have, and how bad were they before surgery? What
Right.
are they at a week? What are they at a month? What are they at 3 months? I think I had you fill that out, didn't I?
Yes, I did.
And what are they at 6 months, a year? Is this nonsense, or is it real? A lot of this is just subjective, right? It's just it's how you feel. Like, I can't get into your brain and say, oh my God, this pain that I had in my arm for the last 5 years, which has been a 10, and suddenly it's not there. Like, I don't know. I can't gauge that.
I know, but look at my blood work.
Right.
I mean, that to me, if there was any doubt in my mind, that to me solidified. I couldn't wait to tell you. I mean, Danny asked me, she's like, have you gotten your blood work? And there was like a silent pause for a second, because I was dying to tell her yes, but I didn't want to say anything, because I wanted to save it, for the show. Like everything now is save it for the show. Don't talk to me. Save it for the show. But
I'm not talking to you. I'm save it for the show.
Yeah, but
but that's awesome.
And do you see a difference in your patients?
Did you talk to your GI guy?
I did, but Dr. Brenner, this is why it's so important to have you on the show, because I find that doctors kind of do the rolling of the eyes. And I also feel in the medical community that women sometimes are not listened as much as men. Like, I think men are taken more seriously. Like, I'm not talking about plastic surgery.
You may be right. You may be right about that.
Yeah, I mean, there's this whole.
What I would say to that is, I when I first started seeing BII patients, I mean, I think I'm pretty good about listening to patients in general, but specifically the BII patients. When I first started seeing these patients, I didn't necessarily believe it.
I didn't believe it either.
And I mean, it just doesn't, because it doesn't make any rational sense. But one becomes two, becomes five, becomes 10, and then it's
And
the
you see
same
a
story,
difference?
and the symptoms are overlapping. And then I was like, I start taking out implants, taking out capsules, and people are getting better. Initially I thought, well, maybe it was just sort of placebo, and maybe there is some degree of placebo
There
to it.
could be.
But like the only way that we're going to know that is to study it, and so that's what we're starting to do.
Well, and it's nice to have doctors like you because, like, for instance, my pancreatic specialist, when he called me, he emailed me. He's like, let's talk tonight. Your work is excellent. Your lab work is excellent. And I was like,
And you're off your medications
I haven't taken anything. I haven't
since
taken
before
the
surgery.
NAC. The only thing I was taking was NAC and a cholesterol medication. And I haven't taken anything. And so he called me last night at 6 o'clock and he's like, what are you taking? Have you been taking? And I'm like, I'm not taking anything. I had the implants removed 8 weeks ago. I said, 3 years, I haven't had a normal lab. And I said, I want to connect you with Dr. Brenner. I'm going to email both of
I
you.
spoke to him
Yeah.
before your surgery.
And I said, but this is my point. I said, because since then, this is why I think my numbers are normal. And he was like, and I said, so if you have any of women that are coming in and they're getting acute pancreatic attacks and you don't know why, just ask them if they have implants. And he was like, oh yeah, okay, yeah. And I said, well, I'm going to connect you with Dr. Brenner, and maybe you guys can, maybe there's something there. But I find that it's nice to have a doctor like you that is actually listening to these women, like me, because I didn't believe in it until I saw my girlfriend was really, really sick. She couldn't even, keep one sentence. She would go from sentence. What was I talking about? And she would do all this. She had her implants removed. 2 weeks later, I said, hey girl, did you get a little nip tuck or a little something in the face? She's like, no. I go, your skin looks amazing. She looked different. I like her eyes. And so it's nice to have doctors like you that don't go, okay, well, there's no medical diagnosis for that, so it doesn't exist.
I have a patient coming up for Monday and God bless her husband, because most of the time the husbands are checked out, but this guy is so on board. He has been so proactive. She's been to, I think, more specialists and multiple doctors in the same specialty.
Yeah, she probably feels like she's going crazy.
Than any patient I've ever seen. And all of her lab work is normal, but there's really just no explanation. So it's like almost like people are at their wits' end, and hopefully,
and they're becoming proactive about it.
Hopefully this will work. Hopefully it'll work. I mean,
I think it will.
I can't guarantee it for anybody. I didn't guarantee it for you.
I wasn't even sure.
Right.
Like this, and I feel like this is what most BII women go through. Like you go through a litany of like blood work, and then it always comes like you have an autoimmune disease, but they can't tell you which autoimmune disease. And then you have beginnings of rheumatoid arthritis, or there's always like they put a boot on my leg because I had burning in my feet, and they put a boot on my leg which didn't do anything. The day after surgery, I've had no burning in my feet at all. It's crazy, and it's just mind-boggling that I kind of did it as a last resort.
Right.
For me, it was like, okay, I was actually writing a letter to my son because I thought I was going to die, or I had cancer and they didn't find it, and I felt like I was dying. I told my husband, if I didn't know you loved me so much, I would think you're poisoning me. That's how bad I felt. To now, 3 years feeling horrible. This was my last resort. I was like, this is the only thing I have left that I could do. I told my husband, all right, like, and he's like, let's do it. Let's do it. And I'm so grateful, one, to have found you. Two, you have a holistic breast team also on staff, which
they're good.
They're amazing, and it's kind of nice to have that.
Yeah,
no other doctor has that.
She's pulled it together for us.
Yeah.
Excuse me. It's nice. I mean, listen, I went to medical school. I did a general surgery residency. I did a plastic surgery residency. I spent more time in hospitals than I care to remember, and more time training than I care to remember. 9 years. It's crazy. I'm a Western trained surgeon. I am. I can't change that. I'm not going back to go do holistic medicine.
Well, no.
Course or whatever training I mean, there's some really great holistic practitioners. They do their thing, and I do my thing. And I just, I don't want them coming into the operating room telling me how to operate, and I'm not going to tell them how to do their thing. I mean, I've always said, even before breast implant illness was a thing, I've always said, like, if alternative therapies are not for everyone, but if they work for you, great. A lot of people think that acupuncture is hocus pocus, but I think if it works for you, I mean, there is a physiologic basis to it. I mean, if it works for you, great. It doesn't work for everybody.
I'm in the middle of the road. I'm Eastern, Western. Some stuff is too hokey pokey for me, and some stuff is, works. So I feel like I like to dabble in both.
Again, there's extremes don't really work for most people. I mean,
yeah, exactly.
I could say, you have breast implant illness, and you go to somebody and they're like burning sage, hoping that you're going to get better. Well, that's not going to happen. Maybe it'll help you afterwards.
Unless you believe placebo. Well, Dr. Brenner, can you tell people where they can find you, how they can find you, your website, your social media handles?
Absolutely. So, I mean, the best thing to do is to call me. I have people.
Call him, because let me tell you, he is amazing. In the office, Danny, all the office staff.
We have an awesome staff.
You have an awesome staff, an awesome support.
All the way through. I mean, front office, Danny, Jihan, our OR team is amazing. Because it's not just about like coming in for a consult. I mean, it's a process. People don't understand that. It is a months long process to do. Even just one surgery is a month-long process. When I sign up a patient, I'm not just signing them up for surgery. I'm signing them up for the preparation for surgery,
right?
The surgery, the recovery.
Well, your anesthesiologist.
She's awesome.
Okay, first time that I've never been sick after a surgery.
She's amazing.
Not even. I'm usually like so nauseous. I felt.
Don't tell Lori I said this, but she's amazing.
She's amazing. Well, your whole.
I'm not gonna let her watch this.
I don't want to sound like I'm blowing smoke, but I swear that they're just amazing. Their staff and your bedside manner. He dealt with me and survived. So.
I did. I survived. That's saying a lot. So yeah, the best thing, I always prefer just calling the office because I'm not usually around answering my Instagram.
The website is
kevinbrennermd.com. The office number is 310-777-5400.
I'll put it down on the screen also. And
then I also have my I have a lot of stuff up on my website. I have a ton. My website is deep. You just have to look through it. But I also, more in real time, I'm updating my Instagram, which is kevinbrennermd. And so, I have videos and testimonials and before and afters and, updates from patients like you and patients like Amanda and everybody else. And, it's not all breast implant illness all the time. I do a lot of different stuff, but I do take care of a lot of breast implant illness patients.
Well, yeah, your work is incredible. And just, you see the before and afters, like, nose jobs, which rhinoplasty, all of it. I mean, Dr. Brenner, I really appreciate you coming in and talking to me and taking time out of your busy schedule. But before you go, I have to torture you a little bit more. And we're going to play a game. It's called Never
Monopoly.
Have I Ever. So I have these little things here.
Okay.
And I have, if you have, and never, if you never, and I'm going to play with you.
Oh, okay.
So, let me get my little game. I play this with all my guests, so just Don't feel so special.
But so you're just you're gonna be asking questions, and it's either never or I have.
Or I have. Yes.
So I don't get to come up with the topics.
No, I try to keep it semi vanilla, but there is some has a little sprinkles on it.
All right, nothing too spicy.
Nothing too spicy. I try to keep it, didn't want to scare you because you need to come back. Okay, Dr. Brenner. Never have I ever gotten heated during a family game night.
Oh, for sure.
Oh, me too.
For sure.
I hate losing.
That's.
Oh.
Yeah. I'm super competitive.
Are you? Me too. I grew up with 6 boys, so I'm taking my space.
I grew up with 1 brother, but I'm still super competitive.
Oh, you are? Okay. All right. Never have I ever skinny dipped.
I have in my pool.
Okay, well that counts.
That counts. Okay.
Never have I ever snooped through a friend's bathroom medicine cabinet.
Oh, I for sure have done.
I have. Yeah. Oh my God.
These are really easy. So
I know.
Far. Yeah.
So what friend?
Oh, I can't.
You're like, I'm not gonna.
They'll never invite me back.
Okay. Never have I ever gone commando.
No. Never. Never. I like my underwear. Sorry.
Never have I ever ghosted. Oh yeah.
Of course.
Yeah. I think most women. I hate panty lines. Okay.
I don't mind.
Never have I ever ghosted someone.
Like in a relationship?
Just in general. Like on social media. I'm ghosting somebody right now. Okay, last one.
Yes.
It's not too torturous, you see.
No, it's not so bad.
Never have I ever joined the Mile High Club.
I never have.
Wow.
Never have. But, it's never too late.
Hint, hint. Thank you, Dr. Brenner.
Thank you.
It was amazing having you. Thank you for being a good sport and playing with me.
Sure.
And again, Dr. Kevin Brenner in Beverly Hills.
Call us.
Yes, call him. And again, thank you. I'm so happy with my results. And I feel so good. I can't really thank you enough.
I love hearing more than anything.
Thanks for listening to Left Unsupervised. Don't forget to stalk us on Facebook, Instagram, and Twitter at Left Unsupervised Podcast. We'll catch you guys next week. Thanks for listening.